A public health intervention can be technically correct and still fail. This is where I want to begin today. I want you to imagine a vaccination campaign. The science behind it is historic. It's very strong. The logistics are carefully planned. The funding has been secured. The health team has the correct protocols, the right cold chain, the right forms, the right schedule, and the right message on paper. But then the uptake stalls. Not because the science suddenly became weak, not because the vaccine stopped working, not even because the community is simply resistant in some vague or dismissive sense. It may stall because the campaign didn't understand how decisions were made in this community. It may not have understood who people trust, who people listen to, what past experiences shaped their relationship with health institutions, what language carries authority, or what a family believes it is protecting when it says no. That is very different diagnosis of the problem. And it's one that I experienced a lot across my humanitarian work, across my global health work, and social impact work, leveraging data and technology for good. The lesson is simple, but it's not small. Technical excellence is necessary, but it is insufficient. In fact, culture shapes whether people trust a health message. It shapes whether they show up for care. It shapes whether they follow a treatment plan. It shapes whether they use a health technology. And it shapes whether they tell their neighbors, parents, children, or their patients, yes, this is safe. This is for us. Yes, this is worth doing. So today, as we start this series on the foundations of culture and health, I'd like for us to treat culture not as an add-on, not as a soft skill, and not as a box check at the end of the training. Instead, I want us to treat culture as one of the indispensable conditions that determines whether health practice actually works. Very briefly, I come to this topic from a mix of fields. I didn't begin strictly within the public health lane. My background includes political science, international relations, humanitarian action, global health, management, and social impact work across diverse regions and institutional settings. That background matters because I've often seen the same pattern where smart, well-intentioned people designed technically sound programs. But those programs struggle because culture, trust, power, and local meaning weren't placed at the center early enough. So my goal today isn't merely to explain concepts. It is to help you think as future public health leaders and health professionals who can ask better, more insightful questions before an intervention fails. We're going to move through 5 connected ideas. First, cultural competence, cultural humility, and cultural safety. These terms and others around culture are often used together, sometimes even interchangeably, but they don't mean the same thing. They have a long and highly debated history. Second, we're going to look at acculturation and assimilation, especially through Berry's acculturation model and why cultural transition matters for health behavior. Third, health information, misinformation, disinformation, and the challenge of the infodemic. Fourth, we're going to look at digital health, acceptability, and cultural tailoring, including why technology isn't culturally neutral. And finally, the health illness continuum and the way people understand symptoms, care seeking, and wellness itself. The thread running through all of this is that people don't experience health in the abstract. No, they experience it through language, family, memory, institutions, technology, trust, and power dynamics. In other words, they experience health through their culture. Let's begin with these 3 concepts that sit at the center of our session today: cultural competence, cultural humility, and cultural safety. A simple way to remember this distinction is that cultural competence asks, what do I know and what skills do I have? While cultural humility asks, how do I keep learning, listening, and checking my assumptions? And finally, cultural safety asks, how does the patient or community experience this encounter? Those 3 sets of questions point in related directions, but they're not the same. Competence generally refers to the knowledge, skills, and attitudes that help health practitioners work effectively across cultural contexts. It gives us a vocabulary. It reminds us that the providers need preparation. It tells us that health professionals cannot assume that one communication style, one model of family decision making, or one explanation of illness will work everywhere. I don't want to dismiss competence. It has played an important role in health professions education. But the word competence can create a problem if we're not careful. Competence can sound like an arrival or an achievement. In practical terms, it may sound like training. I passed the module. I understand this group now, so I can move on to the next. This is where we have to be cautious. Culture cannot be viewed as a checklist. I may use an early millennial reference that may be a bit more blunt. Culture is not like collecting Pokemon, where once you've captured one, you own it, and you can add it to the list. Culture is far more complex than that. Cultures are internally diverse. They change over time. They're shaped by class, gender, age, migration, religion, region, technology, and personal experience. This is what is meant by intersectionality. All of these different dimensions affect how an individual perceives and navigates the world, with culture being an important but not the exclusive dimension. And people don't simply have culture in a flat or predictable way. They interpret it, they negotiate it, they sometimes embrace parts of it while rejecting others. So if cultural competence becomes overconfidence, it can lead a provider to assume that because a patient belongs to a particular group, that a patient must hold a specific belief or behave in a certain way. So you know where I'm going here, that may lead to stereotyping and to being condescending to members of a different culture. That isn't care. That is essentially stereotyping with better vocabulary. This is where cultural humility becomes essential. Cultural humility shifts the emphasis from mastering another person's culture to practicing lifelong learning, self-reflection, and attention to power dynamics. A culturally humble practitioner doesn't assume they know what a patient's culture means to that patient. Instead, they ask, they listen, they stay curious. They recognize that even when they have experience, they're still capable of misunderstanding. And that is not a weakness. In health practice, that kind of humility is a strength. It creates space for the patient to explain what matters to them, what they fear, what they have experienced before, and what they need from the encounter. Then cultural safety takes the conversation a step further. Cultural safety asks us to shift the center of the evaluation. The question is no longer only whether the provider feels prepared, respectful, or well-intentioned. Instead, and more importantly, the question is whether the patient, family, or community experienced the care as being safe. That is a transformative shift. Many institutions are very good at measuring what providers do. Did they attend the training? Did they complete the module? Did they use the approved language? But from a project or program management perspective, all of these may be outputs. They don't necessarily demonstrate a positive outcome. If the outcome is better, more culturally aligned care for the community, then the community itself should be the arbiter of that care. So the deeper question here is, did the person receiving care feel respected? Did they feel able to speak honestly? Did they feel that their history, language, and dignity were taken seriously? Did the encounter reduce harm, or did it reproduce it? We should recall, do no harm is one of the core principles of healthcare. Cultural safety also requires us to name power. Healthcare isn't an equal encounter, especially in Western medicine. The provider often has professional authority. The institution may carry historical weight. The patient may come in with memories of discrimination, exclusion, or treatment, or simply feeling unheard. So when we talk about cultural safety, we're talking about more than simply manners. We're talking about the conditions that allow care to be experienced as respectful, as empowering, and free from avoidable harm. This is why cultural humility and cultural safety aren't nice to have additions to health practice. They're morally important, and they are also practically important. And this is a very important point I want to make. Delivering culturally humble care that is perceived as culturally safe by patients and communities isn't only a matter of being a moral imperative. It isn't how we should behave as a matter of ethics. It is also a matter of the efficacy with which we are at our objectives. It's a moral imperative because if we claim to care for the patient and the well-being of people, we can't ignore the cultural and historical conditions that shape that well-being. But we may forget the fact that in practical terms, because interventions are unable to succeed if they ignore culture, what happens is communication breaks down, trust, which is so valuable and must be nurtured over time, can quickly erode. Adherence to treatment suffers, conflict increases. So here are some major takeaway. Cultural competence is important to give us the tools, but we should pay special attention, and I've tried to uphold this throughout my career. Humility keeps us honest. We should relish a path of continuous learning, recognizing that patients, that communities aren't only meant to be served. They are not the passive beneficiaries, but they should be partners who can teach us. Likewise, cultural safety reminds us that the patient's experience is central. It's not only the output of whether I have conducted these trainings or accumulated these certificates, or how my attention would be evaluated by myself, peers, or institution. Instead, it's what is the perception of that care, or what is the impact of that care amongst patients and the community writ large. So we need all three of them. There is a lot of critique and a shift away from the concept of cultural competence, as we have explained, but we should avoid collapsing all of these into one vague idea. Yo voy a seguir hablando, tú puedes mucho. Now, let's move from the health encounter itself to what happens when people and communities live between cultural contexts. This is where acculturation, assimilation, and heritage consistency become important. Acculturation refers to the process of cultural change that happens when people come into sustained contact with a new cultural environment. This often comes up in relation to immigrant communities, but the basic idea can apply more broadly whenever people are navigating more than one cultural world. Heritage consistency refers to the degree to which people maintain cultural traditions, values, practices, language, or social patterns connected to their heritage culture. Berry's acculturation model gives us a useful way to think about this. It identifies four broad strategies. These are integration, assimilation, separation, and marginalization. The first of these, integrations, means maintaining a connection to one's heritage culture while also participating in the new society. Next up, assimilation means adopting the dominant culture while letting go of much of the heritage culture. Separation means maintaining the heritage culture while limiting participation in the new society. And finally, marginalization means limited connection to both the heritage culture and the new society. These aren't labels we should use carelessly. They're not fixed boxes that people live in forever, despite the very clean character of the grid that you're seeing here on screen. People can move between them. Families can vary internally. One generation may experience this differently from another. So a teenager, a parent, and grandparent in the same household may be navigating cultural transition in very different ways. Why does this matter for health? Because health behavior isn't just an individual choice. It is embedded in food, family, work, migration, language, trust, social pressure, access, and much more. For example, let's look at diet. When people migrate or move between cultural environments, their eating patterns may change. Some changes may improve health, whereas others may increase risk depending on the foods available, the cost of healthier options, work schedules, neighborhood conditions, stress, and social belonging. Or let's think about preventive care. In some contexts, people may seek care early and routinely, while in others, they may wait until symptoms are severe, or maybe when they need urgent care, not because they're irresponsible, but because of cost, previous experiences, family norms, work constraints, fear of documentation issues, the lack of affordable health insurance, or different understandings of when a symptom requires medical attention. Even the question who makes a decision can be culturally shaped. A public health message may assume that the individual is the primary decision maker, but in some households, Decisions about vaccination, reproductive health, elder care, nutrition, or treatment may be influenced by parents, spouses, elders, religious leaders, community figures, or extended family networks. If a health intervention speaks only to the individual, while the decision is actually made collectively, the intervention may miss the real site of influence. This is why it's not enough to say we have a target population. A target population is never a single imagined person. Instead, it contains different histories, different levels of trust, different degrees of access, and different relationships to both heritage culture and the broader society. So when we think about acculturation and health, we should avoid two mistakes. First, we should avoid treating immigrant or migrant communities as a monolith. And the second is we should avoid assuming that more assimilation always means better health. Sometimes there's a lot of evidence demonstrating this. Sometimes it's actually the contrary, particularly with regards to stress and mental health, and with regards to nutrition. Sometimes also to the access to care, given structural difficulties in the US. The reality is more complex. Integration is often associated with better outcomes because people may maintain protective cultural resources while also accessing institutions and opportunities in the new society. Marginalization is often associated with poorer outcomes because people may lose connection to both sets of resources. But even that has to be interpreted carefully. We're not looking for a simple slogan. We're looking for a more precise way to understand how cultural transition affects health behavior and health access. So for practice, the question becomes, where are people actually located in their cultural lives? What do they maintain? What have they had to give up? What systems do they trust? What systems have failed them in the past? And how does that affect the way in which they understand health? That's where better public health work begins. Let's turn to health information. In public health, we often imagine that if we provide accurate information, people will make better decisions. Generally, there's truth to this, but it's only part of the story. People don't evaluate information only by asking, is this scientifically correct? They also ask, sometimes consciously or sometimes not, who is telling me this? Do I trust them? Have people like me been treated well by this institution? Does this message fit what I've seen in my own life? Is it in a language that I understand? Is it being shared by someone I know? Does accepting information create conflict with my family or community? This is why the WHO, World Health Organization's concept of the infodemic is so useful here. An infodemic is an overabundance of information, including false or misleading information, especially during a health emergency like the COVID-19 pandemic. The challenge isn't only that there's false information. The challenge is that people are surrounded by too much information, moving too quickly through too many channels with very different levels of credibility. Within that environment, we need to distinguish misinformation from disinformation. Misinformation is false or misleading information shared without the intent to harm. A person may genuinely believe what they're saying. They may be worried. They may be trying to protect someone. Disinformation is quite different. It is false information that is deliberately created or spread to deceive. It is generated or distributed with a malign intent. Both can harm public health, but they require different responses. If a grandmother shares an inaccurate health warning in a family chat because she's scared, that's not the same as a coordinated campaign designed to manipulate public opinion or undermine trust in health institutions. And the response shouldn't be the same either. And this is one key area in which culture matters. False information doesn't spread in a vacuum. Instead, it travels through existing relationships. It feeds on existing fears and wounds. If a community has had a long history of being ignored or mistreated by institutions, a false claim may feel more plausible because it attaches itself to a real experience of distrust. This is why simply debunking a rumor is often not enough. In fact, if we spend all of our energy repeating the rumor in order to refute it, we may inadvertently keep playing defense on someone else's terms. In fact, if we spend all of our energy repeating the rumor that we're trying to refute, we may accidentally keep playing defense on someone else's terms. We may help to spread the rumor that we're trying to counteract. That doesn't mean that we ignore falsehoods. It means that we have to think more strategically. The strongest approach is to build trusted channels before a crisis hits. Trust built only during an emergency is usually too late. People need to know who the credible messengers are before the moment of fear and confusion. And when trust has been damaged, repair requires more than better messaging. It requires listening attentively, once again, with humility and respect. It requires understanding what people experienced, acknowledging their legitimate grievances, and demonstrating changed behavior over time. This isn't merely a communication campaign. It must be sustained, genuine engagement. This is especially urgent now because AI can accelerate the production and spread of misinformation and disinformation. Synthetic text, images, video, and automated accounts can make false information look more polished, more credible, and more widespread than it actually is. So evaluating health information is now a core public health competency. We need to ask, who is the source? What evidence is provided? Is the claim consistent with trusted public health institution? Who benefits if the people believe this? And how might language, culture, history, or trust affect how the message is received? One last question is crucial here, because a message can be accurate and still fail if it's delivered through an untrusted channel, in the wrong language, or without regard for the lived experience of the people receiving it. One personal example of this, I worked on information management during the COVID-19 pandemic in a program that examined data regarding COVID-19 across different countries in Latin America, Africa, the Middle East, and Asia. And one case that I looked at was how COVID-19 spread across communities in the Amazon region of South America. And we saw a recurrent failure of regional governments to generate public health education materials on COVID-19 in indigenous languages. Instead, they first generated this content in Spanish or Portuguese. Sometimes communities lacked information in their language, and this, unfortunately, had a correlation with a disproportionate rate of COVID-19 infections in many of these communities that were quite remote, hard to reach, and also struggled to get the care that they needed. This brings us naturally to digital health. Digital health includes health apps, wearable devices, telehealth platforms, online portals, text message interventions, and increasingly AI-enabled tools. These technologies are expanding rapidly, and they can be very powerful. But we have to begin with a simple principle. We have to recognize that technology is not culturally neutral. A health app is never just an app. It carries a set of assumptions. It assumes a certain level of literacy. It assumes access to a smartphone, comfort with entering personal data, a particular relationship to privacy. It assumes that reminders are helpful rather than intrusive. It assumes that the user has time, connectivity, language, access, trust, all of these preconditions to leverage the tool. If those assumptions don't match the lives of the people the tool is supposed to serve, the technology may be effective on paper, but fail in practice. This is where acceptability becomes important. Acceptability isn't simply a fixed property of an intervention. It's not something designers can declare by saying, okay, this is user-friendly. Instead, it emerges from how people experience the tool in real life. Do they find it useful? Do they get it? Does it fit their routine? Does it feel respectful to them? Does it create too much of a burden? Does it conflict with their values? Does it expose them to privacy concerns? Does it support care, or does it make care feel more remote? A rating scale can tell us part of that story, but never the whole story. Someone might give an app a decent rating and still not use it consistently, or they may understand the app but avoid it because the language feels cold, the design feels unfamiliar, the reminders feel judgmental, or the tool doesn't match how the household actually makes decisions. So this is where a mixed message approach matters. Qualitative measures can show patterns. Qualitative feedback can help us understand why those patterns exist. A common failure mode in digital health is that teams say they used a user-centered design process, but the users they consulted don't represent the people who will use the tool at scale. For example, an app tested mainly with urban, educated, smartphone-fluent users may not work well with rural populations, with older adults, with people that have limited digital literacy, people who share devices, or people who worry about data privacy because of their immigration status, employment situation, or past experiences with institutions. Surface level cultural tailoring, what may be accomplished via a basic level of cultural competence, can help, but it's not enough. Translating the text is clearly important. Using familiar images may help, but a deeper cultural tailoring asks different questions. How does this community understand the health condition? Who makes decisions in the household? What sources of health information are to be trusted? What role do family members, community leaders, or faith leaders play? How does this tool fit into existing patterns of care seeking? What would make people feel that the tool is for them, not simply about them? And then we have AI. AI-enabled health tools can raise the stakes because they often depend on large data sets, predictive models, and automated decision-making. As we have probably heard quite a bit already, if the data used to train a tool underrepresents certain populations or reflects historical inequities, the tool may perform worse for the very groups that already experience disparities. The quality of the AI tool isn't determined by the algorithm. It is more often determined by the quality of the data that is fed to train the algorithm. If the data is historically biased, the issue isn't merely that AI is going to replicate those biases. It is that it may institutionalize those biases, acting at scale and having an exponential impact on those biases, making it much harder to identify and to repair them, given the closed nature of the algorithm, the difficulty of assessing its outputs in a transparent way. This isn't just a technical concern. It's also a cultural and ethical concern. Whose health knowledge counts here? Who's included in the design? Who gets to challenge the output? Who benefits when the tool works, and who bears the risk when it fails? So the point clearly isn't that digital health is bad. It's not at all. It's not necessarily good or bad in and of itself. It became indispensable during the COVID-19 pandemic, and it holds tremendous potential. The point that I want to make instead is that digital health has to be evaluated within a context, including a cultural context. Its value depends on access, usability, trust, language, privacy, cultural meaning, and community input. A tool is only effective if people can and want to use it. Now, let's connect these ideas to the health-illness continuum. The health-illness continuum asks us to think of health not as a simple binary between being healthy and sick, but as a dynamic spectrum. People move along that spectrum through different levels of wellness: risk, symptoms, disease, recovery, and well-being. The biopsychosocial model associated with George Engel helped challenge the idea that health can be understood only through physical pathology. Are you physically ill or not? Instead, Engel argued that biological, psychological, and social factors all shape health and illness. That was a very important shift. But culture adds another layer that we can't ignore. Culture shapes where people perceive themselves along that continuum. Shapes what symptoms are considered significant. It shapes when someone decides they're sick enough to seek care. It shapes what kind of care feels legitimate. It shapes whether distress is described emotionally, physically, spiritually, relationally, or some combination of these. For example, depression and anxiety don't always present in the same way across cultural contexts. In some settings, emotional language may be direct and accessible, while in others, distress may be expressed more through physical symptoms such as fatigue, pain, or bodily discomfort. If a clinician expects only one presentation, they may dismiss what the patient is actually trying to communicate. The same applies to definitions of wellness. Some people may understand health primarily as the absence of disease, but others may define health through balance, spiritual well-being, social harmony, the capacity to work, the ability to care for their family, or their connection to community. None of this means that the biomedical categories are useless. Of course they're not. They're extremely useful, but they're not the only framework through which communities and individual patients understand illness. So when we ask patients or communities to adopt a treatment, a prevention behavior, or a digital tool, we're not introducing that into an empty space. It's not a void. We should know this already as we've come this far. It's always within a context. We're introducing that into an existing explanatory model, a way of understanding what is happening, why it's happening, what should be done, and who should be involved. If we don't understand that explanatory model, we may talk past each other. The provider may say, this is the diagnosis, while the patient may be asking, why did this happen to me now? What does this mean for my family? Is this something I can talk about? Will treatment change how others see me? Is this care safe for me? That's why humble practice requires us to ask better questions. A simple practice question might be, what do you think is happening? Another might be, what worries you most about this? Or who do you usually talk to when making important health decisions? Or what would make this plan easier or harder for you to follow? These questions can reveal much more than a checklist ever will. So at this point, let me bring up this simple visual roadmap that pulls everything that we've talked about together in one place. I know this is a lot. I don't want you to feel overwhelmed by it. Don't read everything that's on the screen. Instead, this infographic is meant to be a helpful recap. You can pause here and expand it, make it yours. It's not new content. Let's start here on the left with cultural competence. Cultural competence gives us knowledge and skills, while cultural humility is the ongoing practice of reflection, listening, and lifelong learning. It helps to keep us in a posture of reflection that can extend a lifetime. Cultural safety asks whether the patient or community experiences care as respectful and free from harm. So the movement is from knowing to reflecting to ensuring that people feel safe and well cared for. Now, let's move on to the second session right here. Berry's acculturation model. We see the grid right here of integration, assimilation, separation, and marginalization. This reminds us that people and communities navigate cultural contact in different ways. They're not just abstract categories. Let's remember that even though we're displaying it as a grid, these are not clear-cut boxes. Instead, they can be fluid and people can move between them, and there are intergenerational differences as well, even within a single household. These categories can influence diet, family roles, preventive care, trust, and health-seeking behavior. Now, let's move on here to health information. We talked about the infodemic. We also talked about misinformation and disinformation. Misinformation is quite widespread. It's the false or misleading information shared without the intent to harm. It is spread inadvertently. The important point here with misinformation and disinformation is that regardless of the intent of the emitter, people need to evaluate health information more critically. And we need to recognize that they do so based on trust, building on lived experience, on language and community context. So accuracy matters greatly. Of course, we have to transcend misinformation, counter it as well as disinformation, but credibility is also relational. Finally, let's move on here to the right side, acceptability and digital health. A tool may look effective in theory. It may be well-defined, but if people can't access it, don't trust it, and can't use it comfortably or don't see it as relevant, it may not have the intended impact. Now, going to the bottom banner, I'd like for you to read this big picture right here. Culture shapes trust, behavior, communication, and whether health interventions are used and experienced as safe. This message captures the whole session so far. I want to close with 5 takeaways. The first one is that cultural competence, cultural humility, and cultural safety are related, but we know very well now that they're distinct. Competence is valuable because it gives us the tools. In fact, that's why for many decades it was the prominent framework. Cultural humility keeps us learning, while cultural safety centers the experience of the person receiving the care. The second point I want to make is that acculturation has real health implications. Immigrant and migrant communities are not a monolith. And cultural transition can shape diet, prevention, care seeking, and trust. The third point is that health information is being distributed in ever greater quantities, and accurate information is being mixed with misinformation and disinformation to sometimes generate an infodemic. This means that we can't simply rely on accurate messages, because an infodemic, it is also influenced by culture. We have to build trusted channels, and we have to understand why people believe what they believe. The fourth takeaway is that health is not culturally neutral. In fact, apps, telehealth, and AI tools, so much of them are developed here in San Francisco Bay Area, in Silicon Valley, or in the US. And the culture of the scientists, engineers, and business persons involved seeps through into how these tools are built. This means that they have to be assessed through access, usability, language, privacy, trust, and equity. And the fifth and final point I want to make is that the health illness continuum should always be interpreted through a cultural lens. Symptoms, thresholds, and care pathways aren't experienced in exactly the same way everywhere. The guiding principle I want to leave you with is that culture is not merely an add-on to effective public health practice. Instead, it is foundational. Every decision about how you communicate, how you define interventions, how you use technology, and how you build trust is shaped by cultural context. So I want to invite us all to make a greater effort to gain awareness, to remember to be humble, to have an endless curiosity, and to get this process right. Not only to improve individual encounters, but to build health systems and public health interventions that are more effective, more equitable, and more worthy of the communities that they're meant to serve. Thank you very much for your time.